All right, so we'll go over chapter 14, 15, quiz first. All right, the first question, postpartum hemorrhage is treated with the following medications except carboprose, oxytocin, methergine, or nifedipine.
Nifedipine.
Correct. A precipitous or rapid labor increases the risk of postpartum hemorrhage. True or false?
True.
Postpartum hemorrhage is described as a blood loss greater than how many milliliters in vaginal deliveries?
500.
100.
The newborn has blank blank that is also referred to as non-shivering thermogenesis and promotes heat production.
Brown
Brown
fat.
fat.
Got it. And then the last one, in a newborn, hypoglycemia is noted when the blood sugar is less than
40.
40 milligrams per deciliter.
Got it. Okay. So 1 was nifedipine, 2 was true, 3 was 500 milliliters and that's how much the blood loss is in a vaginal delivery. The newborn has brown fat that helps promote heat production, and the blood sugar that we are concerned about in a newborn is less than 40, which is hard for some students because they're so used to adults. And 40 we be treating. All right, now let's go to today's. All right, kangaroo care is described as?
Skin to
Skin
skin.
to skin.
Got it. The preferred and safest method of temperature taking in the newborn is?
Axillary.
A life-threatening lung disorder that results from small undeveloped alveoli and insufficient levels of surfactant is known as?
Respiratory distress syndrome.
Got it. A post-mature baby will have?
Dry
Right.
crack.
Skin.
You got it. And a group of signs and neurological behaviors exhibited from abrupt discontinuation of various substances, such as heroin, is known as?
Neonatal abstinence syndrome.
Correct. And I forgot the E in it, but yes. All right. And so then kangaroo care, skin to skin. The safest way to take a temperature is axillary. A life-threatening lung disorder due to insufficient levels of surfactant is known as respiratory distress or RDS. Post-mature, you'll see dry skin. Neurological behaviors will be neonatal abstinence when they are getting abrupt discontinuation of substances. All right. All right, so we're going to watch this video. This video is going to go over preterm respiratory distress in the newborn. Some things I want you to think about when you're watching this is pay attention to the medications that they're going to be administering during this this resuscitative event of this newborn. Listen to the report, the SBAR report that they receive about mom's prenatal history and what precipitated this baby and mom to have issues. I want you to pay attention to how the physician is amazing, but look at the whole team. When we go through this, watch the whole team and how they work together. And the last thing I want you to look at is when the physician goes and talks to the dad and look at his bedside manner. So they're the things I want you to pay attention to when you're watching this, but you can certainly write down these medications. We're going to go over those again. Whoops.
An emergency is developing in the labor and delivery department.
This is a 34-week premature baby who's being delivered by cesarean section. Okay, let's go. She's in there. Let's go. So we're taking our full transport team down to this delivery.
A new mom is having severe complications and her baby needs emergency care.
The mommy has an abnormality of the placenta, and she has a placenta percreta. So that makes it a very high-risk delivery.
Dr. Stephen Elliott and his team from the neonatal intensive care unit are always on call.
It's natural to feel anxiety because we never quite know what we're going to get at a delivery.
The team has all the equipment they'll need to keep this baby girl alive.
So taking our transport rig, it has the incubator for the to keep the baby warm. It has ventilation and monitor equipment on it, and it's also equipped with intravenous pumps.
They're already on their way to the delivery room.
We expect everything to go smoothly, but we're ready for everything. Hopefully the potential hemorrhage is a maternal issue and not a baby issue. But it's also always a possibility that the baby may lose a lot of blood if there's a lot of hemorrhage from the placenta. So what we're thinking about before we go into the delivery room is we're thinking about that baby might need volume, it might need a blood transfusion, and it might need cardiovascular support.
Dr. Elliott quickly collects the newborn.
Let's go. No, let's go. I'm not going to save any time by someone being there 10 seconds earlier.
The premature newborn is alive, but struggling.
She needed respiratory support. We needed to put a tube into her lungs and support her breathing.
During the pregnancy, leaking amniotic fluid damaged the baby's lungs, leaving them underdeveloped.
Erica, we have Robin setting up the ventilator.
Yes, we do.
Okay. We then brought her back to the neonatal intensive care unit. We anticipated a baby who was going to be quite well and not need very much support.
But that wasn't the case. The team will spend the next several hours helping the baby breathe. This newborn girl was born with underdeveloped lungs and is fighting for her every breath.
When she was born, she had considerable difficulty and trouble with her breathing.
The newborn needs several life-saving medications.
I need 30 mLs of normal saline. I need a single lumen and a double lumen, 3.5 French. We'll take 4 mLs of D10. B, I need 0.4 milligrams of morphine. I need 0.4 milligrams of Pavulon.
For a baby just hours old, the dosage must be precise.
The normal saline, I've got 3 of these. You can use these.
I need 5 mLs of surfactant, please. I need a stat chest x-ray, please.
I have a D10 right here. Okay, can D10 run, please?
4 mLs. Marcus, I could take some cloth drapes here as well.
With decades of experience, Dr. Elliott knows exactly what the infant needs.
I need a single lumen catheter, please, as well.
Yes, she's getting it.
Can we get a dopamine infusion set up?
100 mics per ml?
Probably a high concentration.
Do 3,200 mics per ml?
Yeah.
Okay, do you want heparin in that too?
Yes.
Yes.
We'll
Get that.
put it through the UVC.
Okay.
Dr. Elliott must now perform an extremely delicate procedure. The baby's umbilical cord will serve as a lifeline, allowing medications to trickle into her tiny body.
And the
UVC.
UVC right now is at 11. And we're going to go ahead and secure it. Can I take a double lumen, size 5, please? I'll take another blood gas syringe. I'll take a blood sugar and a blood gas from here, please.
The baby is finally stable, and Dr. Elliott now has a moment to check in with the baby's father.
I met you in the waiting room just before the C-section. We do take time out as much as we can to educate and inform the families exactly what's going on. We encourage the families to come in and be with their babies, even during these critical times. After all, it's their baby, and it's their flesh and blood. It's their family, and we feel that they have a right to be there. It's very overwhelming for families. families expect a normal newborn. I think the biggest problem that she's got is that, you know how mommy had a very small amount of fluid in the sac. That affects the lung development, and so the lungs are very underdeveloped because there was a very small amount of fluid. We try and reassure them, and yet at the same time give them enough information to help them understand what's going on. When babies are admitted to the neonatal intensive care unit, it's quite a harsh environment. It's quite shocking for families to walk in and see their babies surrounded by IV lines, by cardiac monitors, electrodes. There's a lot of beeping, there's a lot of activity, a controlled level of chaos as multiple people are performing their functions in the resuscitation. We were anticipating the worst, hoping for the best, but we're down in the trauma OR and this baby clearly has hypoplastic lungs. So we've intubated, we've given surfactant, and I've just placed lines. We've got our blood gases pending, and she has received morphine and Pavilon. So she's sedated and she's paralyzed.
The team has done an amazing job. The newborn girl has been stabilized.
At this point, this baby is reasonably stable. She does still need a lot of support on the ventilator.
She will now be transferred to a regional facility that specializes in the long-term care she'll need.
It's not going to be a quick fix to this problem. Her blood work numbers that tell us how her lungs are functioning tell us that her lungs are very sick. She's going to need additional help. We're going to have to transfer her. I'm working on where exactly would be the best place for her to be transferred to because she's going to need a lot more support in the next couple of days. She needs a lot of cardiovascular support. I anticipate that eventually she will do well, but she's going to need critical and intensive care for the next several days.
Okay, so before we move on, what's going on with the baby?
Baby's lungs
Baby's
are
lungs are underdeveloped.
Correct. And what caused that to happen?
lack of amniotic fluid in the mother's sac and the sac.
Right. Does anybody remember what he said? What complication did mom experience?
Placenta accreta.
It was actually placenta percreta. Very similar. Very similar. Does anybody know what placenta percreta is? We know what placenta. We talk about placenta accreta. It's very similar. So in placenta accreta, remember the amniotic sac and everything all attaches, and it actually implants too deeply into the uterus. So when the baby's born, mom has a high increase of hemorrhaging, and you'll see that she'll have that severe pain and very, very bright, frank blood. Where placenta percreta, 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 the placenta is it attaches and grows through the uterus. So again, it's very rare, but it is a complication. If she didn't have prenatal care, they might not know about that. But once they know, they need to do a C-section. So that's what happened with her. So she had the C-section. She was leaking amniotic fluid as well, which was damaging the lungs. So this baby was extremely, extremely sick, right? How do you think, how did the team work together?
They had really good communication.
They did. They
Like
did.
everyone knew what to do, and the doctor was really clear on what he wanted.
Exactly. And very calm.
Yeah, very calm.
Yeah. Could you imagine if he starts screaming and yelling at his team? I told you I need this. Could you imagine under under what they're going through, because they have to be very exact with everything they're doing right now to keep this baby alive and to make sure that this baby has a good outcome, right? So could you imagine if if he just kind of started going off the handle and yelling and screaming and getting really impatient with his team? How that could change that outcome. All right, so I told you to listen to the medications that he was asking for. What are some of the medications he was asking for?
Surfactant,
Good,
Morphine,
good.
dopamine,
Mm-hmm. Good.
Normal saline.
Yes.
D10,
Uh-huh.
and heparin with D30 with heparin.
You got it. All right, so let's talk about these medications. Um, Now, when we talk about getting an infusion, when we give fluids, even say to the mom, we would give her at least a liter bag, right? If we needed to, to increase her volume. This baby's getting 30 milliliters. So you got to think, how small is this baby? How small is her system? So even the dosages probably to you seem really small. So 4 milliliters of D10, 0.4 of morphine, 0.4 of the tebulin, which I believe that's what he said, but it's really hard to hear that one. So I always kind of bypass that one because I didn't quite catch that when I've listened to this like a gazillion times. The surfactant, 5 milliliters of surfactant, the dopamine, the heparin, and they're very specific about the dosages. So we kind of know that the fluid is to help with the pressures, but it's also going to help with that dopamine and with everything else just to keep that baby hydrated. The D10, what do you suspect be their concern with that they need to give the baby D10?
low glucose,
Correct. So hypoglycemia or to offset the hypoglycemia. And also, nutritionally, because right now this baby's not getting anything. This baby's not going to be being breastfed. This baby will be getting, will be getting, tubed for, feeding once they get the baby stabilized. Why are they giving morphine?
so the baby's not in pain.
Pain. It also helps to keep the to stabilize the vital signs, stabilize the heart rate, right? They're going to be doing a lot of treatment. They're going to be doing a lot of, they're intubating. They're doing a lot of different things. They're going to be sticking and stuff like that. So good. 5 milliliters of surfactant. Why is the baby getting surfactant?
To help develop the lungs.
Correct. Does anybody know how is surfactant administered? Does anybody remember from your
Isn't
reading?
it is it
Intratracheal.
Correct. Correct. It's given via ET tube. Correct. Dopamine infusion. Why would they be getting a dopamine infusion? Think about the cardiovascular status of the baby.
Promote blood pressure.
Correct. Yeah, this baby's cardiovascular status is lack of better words is kind of in the toilet right now. So they're going to be giving all this medication. He said the baby has hypoplastic lungs. So hypoplastic lungs is basically it. We're going to talk about that a little bit later when we talk about congenital malformations, but it could be a congenital malformation. It also could be because of the incomplete development of the lungs. He did say that he thinks that this baby is going to have a good outcome. They just have to get over this humongous hump right now with the baby. So I don't think that the hypoplastic lungs are due to congenital malformation. I think it's just more due to what was going on with mom that caused the leaking of the amniotic fluid and caused the issues. They're also concerned about hemorrhaging, and they're concerned about mom hemorrhaging and baby hemorrhaging. So they're kind of watching for that as well. And does anybody remember what lab they would be looking at to see how effective the surfactant was?
The LS ratio.
Correct. And if mom did not have gestational diabetes, what is a normal LS ratio we'd be looking for?
2 to 1.
2 to 1. Very good. Very good. And then the last thing I asked you to look at was how he communicated with the dad. What do you think about that?
He
He was
provided
very
a lot of teaching.
Yeah, he did a lot of teaching. What else? And that's good. I heard somebody.
very direct. Like he did let the father know it's going to be a long road. That's not something that's going to be fixed right away.
Good, good. I liked how he used everyday words and didn't use big medical jargon with the dad. Was very his bedside manner and the way he interacted with dad was pretty much in alignment with how we saw him act the entire time. Wouldn't you think?
Yeah, very
Yeah.
calm.
Yeah, I liked the whole I liked the whole scenario of how everything went down. And I think just by his acting, and being calm helped his team. I'm sure as much as the baby is a newborn, do you think that baby picked up on that calmness and the whole atmosphere is going on? Absolutely, right? So I think, very, very good situation and hopefully a very good outcome. I never did, I'll have to follow. This is probably a couple of years old now, but as far as outcomes, I don't know, but did a nice job. Nice intro to what we're going to be talking about today. All right, so it leads me into respiratory distress syndrome, and I'm just going to kind of go over some key things with respiratory distress. So basically, it's a life-threatening disorder, and it's related to undeveloped or insufficient levels of pulmonary surfactant. That is one of the things. We're going to talk about many things with respiratory distress because there's a lot of other complications that happen in the newborn that can also cause respiratory distress. And we'll talk about them, but some of the things are hypoglycemia. If the baby has really low blood sugar, especially if they're born to a mom that had gestational diabetes, then that low blood sugar is going to make that baby work harder. They're going to start getting having problems breathing because they're working harder. Their heart rate's going to be dropping. They're going to, start getting anxious. So that's going to cause it. Another issue that can happen is problems with thermoregulation. So if babies start getting what's known as cold stress, that is going to, again, make that baby work harder. That's going to, that hard work is going to burn the calories faster. So it's going to lead to hypoglycemia, which is going to lead to respiratory distress. So if you can, in your notes, kind of put like a triangle, and you're going to see these things linked together a lot. And this will help you as you're taking your exam and as you process information and you're going to clinical. So if you make a triangle, respiratory distress, cold stress or hypothermia and hypoglycemia are kind of all interrelated. As far as if one of them if the baby starts having an issue with one of those, generally the other two are going to follow shortly thereafter. So you always have to watch those three systems. All right, so neonatal respiratory distress can also be due to genetic problems. It can be due to disease processes. So if mom was GBS positive and we didn't know that she was GBS positive because she didn't have any prenatal care, or didn't follow up with her prenatal care, and then she comes in and she either delivers precipitously or if she delivers before she comes to the hospital. I had an interesting conversation with a student in one of your cohorts that works at one of the ERs in the area that does not deliver babies. And I was very shocked at the amount of deliveries that occur and that are brought into this ER that used to have a mother baby unit. So something is in the back of my mind that I want to discuss with the managers on the unit and maybe, look and see if there's something we can do, because it sounds like it occurs more than it should. But anyway, so a mom with that's GBS. Other factors that can increase the risk is if the if the baby has siblings that had respiratory distress issues, then this baby has an increased risk of having respiratory distress as well. Diabetes in the mother, and that's because the diabetes in the mother causes hypoglycemia in the baby. Does anybody know why mom having diabetes causes hypoglycemia in the baby?
Because she'll
Because
have high levels of insulin.
Well, she has high levels of not insulin.
High levels of glucose, which makes the baby's body produce more insulin. And then once they're detached after birth, isn't the baby's insulin amount still higher, which drops the blood sugar?
Bingo, you got it. Absolutely. Right. So the baby's their pancreas, all their organs are immature, right? Because they're new. They're brand new to this world. So all their organs are immature. So this baby is used to having this constant flow of glucose throughout, from mom. Even if mom's blood sugars are maintained, we can't, they may be maintained at that initial stick, right? When she checks herself at her fasting. But if we drew her A1C, we may see an elevation in general, right? So even though she tries to control them, there is that increase in glucose that's circulating through the baby's system. And then the baby is producing insulin to counteract this high amount of glucose. And then when the cord is cut, you're exactly correct. This baby's body is still producing insulin, but there's no more glucose. So then this baby develops hypoglycemia. Another risk factor is cesarean or induction before the baby's full term. Problems with delivery that reduce blood flow to the baby. And we talked about some of those when we talked about complications during delivery. Multiple pregnancies and a rapid delivery. Can anybody tell me what would be some reasons why a rapid labor could cause respiratory distress syndrome?
If they don't have time to go through the birth canal, then the contractions don't have time to push the fluids out of their lungs.
Very good. Great answer. Exactly. So they're not getting that compression, which is not pushing out that fluid. So then the baby may have some fluid still in their lungs and they're going to have problems breathing. Good job. All right, we talked about this. I just want to reiterate. So the LS ratio is a test that is going to be used to determine if the lungs are developed, if they are mature. Term babies can still, even though they have their surfactant, there can be different things that can decrease the amount of fluid. So remember we talked, this mom had leaking amniotic fluid, which that damaged it. So you're going to see other issues that can counteract, and even a term baby can have to receive surfactant. So the two ratios I want you to know is an LS ratio greater than 2-1 in a non-diabetic woman, and an LS ratio 3-1 in a diabetic. Okay. So complications, I talked about most of these already. So complications of respiratory distress, we talked about hypoglycemia. I told you about, cold stress. And I don't even think I even have that on there on this list. So problems with PDA, with the patent ductus arteriosus, which is basically either a mild or a major heart murmur, my brain there, heart murmur, pneumothorax, and yeah, obviously anything respiratory, bronchopulmonary dysplasia, pulmonary edema, hypotension, anemia, retinopathy of prematurity. Retinopathy of prematurity is due to high levels of oxygen. And so the reason why that's a complication is because these babies who have respiratory distress syndrome are being given oxygen and at times high levels of oxygen. Seizures and also hemorrhage, and some of those are severe complications. And we're going to be talking about a lot of these as we go further along. So this is really important. Really make sure you understand these characteristics of respiratory distress and be able to differentiate respiratory distress versus something, say, cold stress or hypoglycemia. So I kind of put in red the really big telltale features, and then I'll show you a video in a second of exactly what's going on. So these babies have really poor color. They will also have very poor tone. Did you guys take a look at that infant in that video that was having trouble? Did you see the tone was very floppy and the baby just had his arms extended? And did you guys notice that?
Yeah.
Yeah.
So poor tone, poor color. They're probably mottled or pale, and it could be due to the poor circulation because they're not getting enough, circulation of the, to the heart and to the lungs. But it also could be due to hypothermia, that they're really cold. So it can be a combination. The baby can have edema as it's progressing. And then the biggie things you're going to be looking at with their assessment as far as their vital signs is they're going to have tachypnea. Now, what is a normal respiration for an infant?
Is it 30 to 60?
Correct. So in these infants, they have respirations of 60 breaths per minute or more. You're going to see tachycardia. Remember, our normal is 110 to 160, so they're going to have a heart rate greater than 160. And these other two bullet points here that I have in red, grunting respiration and nasal flaring, and also significant chest retraction. So you're going to see it in their chest, and they're going to have periods of apnea. These periods of apnea are different from the newborn that has all newborns have irregular breathing because they're new and they're, again, everything is immature yet. But the difference between a baby with respiratory distress having periods of apnea and a normal newborn having periods of apnea is the baby who has respiratory distress is going to have periods of apnea with tachypnea, with grunting respirations, being very flaccid, being cyanotic, whereas the newborn who's having irregular respirations, but everything else is fine, then that's not a reason for concern. Does that make sense?
Yeah.
Okay. All right. So I'm gonna play this little video. It's a little disheartening to watch, but what I want you to be looking for, I want you to be looking at the subcostal and intercostal retractions. Remember I said there's significant, if you look at your fifth bullet point down, I have it highlighted in yellow. There's significant chest retractions. I want you to be watching for that. I want you to try to watch for the nasal flaring. It's a little bit hard because the baby's turned to the left. So it's a little hard to see the nasal flaring, but I want you to really listen for that grunting breathing and watch how fast this baby's breathing. Okay, I'm going to play it one more time just so you can kind of see. So you're going to be looking for the tachypnea. You're not, if you're listening with your stethoscope, you would hear how fast the heart rate is going. See if you can see the retractions. You're going to hear the grunting, and try to look and see if there's nasal flaring. Okay, so you can see now the color, it's hard to tell. You can see the tone, the baby's very flaccid. We can't really tell temperature wise. Baby doesn't have a lot of edema, but you can definitely see the, if you really look, it's hard to see the nasal flaring, but it is occurring. But you can definitely see that chest retraction, and you can hear those grunting breathing and see that fast breathing. So these are your characteristics of respiratory distress. So in an infant, when they're born, we're going to be doing ABGAR scoring, right? And if they have a really poor ABGAR score, or you're looking at them and you don't even, how many have been in labor and delivery? If anybody's been in labor and delivery, if you saw them doing the app, you might not, they're not going to sit there and get their sheet out and say, okay, their heart rate is this, we're going to score them that. They're doing that in their head, like as they're looking at them, they're kind of calculating everything right away. So I put here some different things that would need to be in place for resuscitative assistance. So if they're taking a look at this baby and this baby is just not looking good, they got poor tone, poor color, respirations are really, really fast. They've got this difficulty breathing. They're going to be doing different things. They're going to be warming the baby because remember hypothermia, cold stress, positioning, clearing that airway as needed, drying, stimulating, repositioning, administering oxygen as needed. Maybe they need positive pressure ventilation versus just, just a little, general O2. If the baby is, if it's significant, if the ABGARs are significantly low, they may be doing chest compressions, and then they're going to be administering some of those medications that you saw in that first video. So at this point, they may be trying to do these things, and at the same time there's a team working on mom. Maybe mom in a episiotomy, or they're helping her because she's now delivering the placenta. So they're going to try and do all this stuff very calmly, especially if mom is in the room. They're going to, dad are in the room, or the partner's in the room. They're going to be doing all this stuff calmly because most of the time they can get this baby to kind of bounce around and give it a little bit of extra, suctioning, positioning, warming the baby up and stuff like that. And the baby can bounce back. And then they're able to give the baby over to mom. Or in some situations that baby's being whisked out immediately and taken to the NICU. Anybody have any questions? All right, so resuscitative management, I kind of talked a little bit about on the slide before. So they're going to be suctioning. Remember, sometimes they may have some, meconium aspiration. So they might have, keeping that baby in kind of, and this is the baby that, they're already thinking in the back of their mind, we're going to have some issues with this baby, is keep that baby head down before that first gasp, especially if mom had some meconium in her amniotic fluids. They're already expecting that there's going to be an issue. Kind of clearing the passageways. And then after baby's starting to, takes a couple breaths, getting that baby more level, getting that baby underneath the radiant heat warmer, drying that baby and maintaining that temperature. And I put that in red because I really want you to kind of have, good idea, because I want you to know what a normal temperature is, what a normal pulse is, and normal respirations. I'm not going to expect you to tell me the blood pressure of the baby. In traditional mother baby, you're just doing temperature, pulse, and respiration once the mom is on the floor. If you're going in the NICU, they're going to get into a lot more with the blood pressure, but for my purposes, I'm not going to expect you to know the blood pressure. But for the temperature, we're looking at anywhere between 97.7 and 98.6. So anything lower than that, we are concerned. So the best thing that you can do is is dry that baby. You're going to be drying the baby and then using a clean bath blanket to wrap the baby up. If possible, get that baby skin to skin, and that, get that baby onto mom, and then mom's got the covers. That's going to be great. But as long as everything else is okay, as long as respiratory status is good. We talked about these drugs. So I remember I told you I was going to come back to those drugs in the in the birthing area. So oxygen, I know a lot of times we don't think about oxygen as a drug, but it is. It is one of the most often used medications in general, more than we realize. If the newborn has not responded with a heart rate greater than 60, then we need to start resuscitative measures. And so I kind of broke down these meds that I want you. Epinephrine is another one that we didn't talk about in the video, but epinephrine is used for persistent bradycardia. And basically, this just don't go into a lot of detail on the meds. If you know what I have on my PowerPoint slide here, you're golden. All right. Don't go into a whole lot of detail. But just know that epinephrine is used for persistent bradycardia. Sodium bicarb, again, was not mentioned in that video that we watched, but sodium bicarb, you'll hear that being used to correct metabolic acidosis. Dextrose, we did talk about that, and that is for hypoglycemia. If the baby is an NAS baby and has a lot of a lot of issues, or if the mom had a lot of narcotics during labor and had a very precipitous labor, the baby may need to have reversal. And so naloxone or Narcan would be used to reverse narcotic depression. Everywhere is different. So some hospitals may or may not use that. So but still make sure you understand that is for narcotic reversal of narcotic depression. Volume expanders. In the video we watched, they asked for normal saline. You could also hear lactated ringers. So either lactated ringers or normal saline for hypovolemia for volume expanders. Whole blood and packed red blood cells may be needed, especially if there's suspecting hemorrhage with the baby. And if the baby's really getting shocky, like we said, to help out with their blood pressure, then dopamine would be used for shock and for low blood pressure. So they're the most common that you would see in the resuscitative, I say in the birthing area, but in the birthing area for use for resuscitative measures. So again, just know what's on my slide here and you'll be good. Don't go into your drug handbook and try to, get a lot more information on it. I'm keeping it very simple here for you. The next medication is your surfactant agents, and I put all the different names that you may see it. So we hear it as surfactant, but what is the last letters of surfactant that's common in these other three types?
INT.
Right. So you may hear it as poractant, calfactant, or baractant. So just know that if you see that TANT suffix, then I'm talking about your surfactant agents. And your surfactant agents, they're given by by intratracheal instillation. And just so that you know what surfactant is actually doing, I put it here in that second sentence. It basically lowers the surface tension forces that are causing these these alveoli to collapse. So that's how it's working. Any questions on the medications? Okay, I'm keeping an eye on time. I'll probably give you a break in about 5 minutes. So clinical therapy, if at all possible, we want to prevent problems with respiratory distress and problems with the lungs before this baby's even born. So we're going to start with mom, right? And if we know this baby's preterm, if we know that these lungs are not formed, now I'm not sure what the situation was with that video that we watched, but if we know ahead of time, we want to administer those antenatal steroids to mom. Remember, we talked about that in prenatal. So we want to administer those steroids to mom prior to delivery to enhance the fetal lung development. So that's best case scenario, is get those into mom ahead of time. If we need to give the surfactant, that's obviously postnatal. We're giving a surfactant, and that's being delivered through an ET tube, like I told you. And we're looking to see an improvement in their oxygenation status or respiratory status. That's what we're looking for, to know that the treatment was effective. Other things you'll be doing, ventilator therapy, you're going to be doing blood gases, which we're going to be talking about, pulse ox. If there's any acid base imbalances, we're going to be monitoring and intervening, maintaining the temperature, making sure the baby is getting adequate nutrition. And also these babies are at higher risk for infection. So we're really watching their temperature. And newborns, unlike adults, newborns actually do not get a elevated temperature with infection. So it's one of those oxymorons that you're kind of watching. You're going to see other, they're actually going to get they're going to get hypothermic when they get septic. So, and then of course they're going to have other problems. And then the last medication we did talk about was the morphine, which is analgesics, and also that sedative effect, because especially if they're intubated, we need to be sedating these babies. All right, I think I'm going to pause my record. All right, so I'm not going to reteach ABGs. I only have one question on the exam, on exam 3 on ABG. So it's not like it's going to be all about ABGs, but we do discuss ABGs when we're talking about newborn respiratory distress. So there will be a question about it. These are the parameters that I want you to know for interpreting the ABGs for me. So for your pH, 7.35 to 7.45 is my parameters that I want you to keep to. CO2, 35 to 45, and your HCO3, 22 to 26. I do have a link here, and I'll just open up, not going to play it or anything like that, but registered nurse
How great is it
RN.
that we get to
Well, I guess I'm going to play it.
tell everybody how Liberty Mutual customizes your car insurance, so you only pay for what you need.
All right.
I certainly didn't invent deodorant, but I changed just about everything about it.
All right.
Hey everyone, this is Sarah.
Anyway, I'm going to pause her video there. She does a really good job. She calls it ABC tic-tac-toe. If you had Professor Terry, I think she, if I remember correctly, when we used to teach together, I think she called it like who's your daddy? I don't know. So, but whatever works for you on how you interpret them, whatever, is basically, what you want to go to. But there's one question on the exam. So don't get yourself like, I don't want you spending 3 hours trying to relearn ABGs. Make sure you have a basic understanding. I am only going to ask you, is it respiratory or metabolic, and is it acidosis or alkalosis? I'm not going to ask you the compensatory mechanism. So it's just going to be those two. There's another diagram there that might help you when you're doing it. So I'm going to do 2 for you, we're going to practice 2, and number 1 and number 2, I just want you to tell me, is it respiratory or is it metabolic? And is it acidosis or alkalosis? So take about a minute, and I'll give you a minute to work on those, and then we'll go over the answer. All right. If you're not sure, I'll share the answers with you, and then you can go back to those. So number 1 was respiratory acidosis. and number 2 was metabolic alkalosis. So again, don't need to tell me, was it compensated or uncompensated? I'm not going to ask you that. This will be a fill in the blank. So you're just going to write out respiratory acidosis or metabolic acidosis or respiratory alkalosis or metabolic alkalosis. That's all I'm going to be looking for. Any questions? All right. All right, I talked about one of the complications of respiratory distress as being PDA, patent ductus arteriosus. So we're going to talk a little bit about that. So it basically occurs when the ductus arteriosus remains open after birth. A lot of times it is really insignificant. Many babies are born with a very mild opening, and then it may close a couple days later, a couple weeks later, a couple months later. If it's significant, the baby will need to have surgery. You're going to see it more commonly in babies with lower gestational age and weight, so your preterms. Complications, one of the big complications, again, it'd be more of a significant one that's going to require heart surgery, is CHF. Chronic lung, renal failure, necrotizing enterocolitis, which we're going to talk about in a little bit. You'll see that. That's basically sepsis of the bowel, and intraventricular hemorrhage. So you'll, when you're doing your assessment, you may or may not hear a heart murmur. If it's very, very minimal, very mild, you might not initially hear that. You'll see some tachypnea and some tachycardia. Again, these are if it's more significant. This baby will be working harder to breathe, very bounding pulses, and they would send the baby for an echocardiogram to confirm. And depending on how significant it is how they're going to treat it, whether they're going to do a watch and wait and see, or they're going to schedule surgery for the baby. If it's causing CHF and causing a lot of problems with the flow of the blood, and then diuretics would be one of the treatments for the CHF and for the edema. A cardiology consult. And again, like I said, surgery, I'm not going to ask you about different types of surgery mechanisms. Just know that they may do sutures. They may, the surgery basically is what I want you to know. And again, it's going to be for a very significant, and it's causing a lot of hemodynamic issues with the baby. But I'm not going to ask you about these surgeries. I just listed them there kind of more for an FYI for you. A big one that we worry about with babies who are being tube fed. And the big key here is they are being tube fed with formula and not with breast milk. But these are formula fed infants that they're in the NICU, and they're not getting the nutrition they need. What they try to do is use donor milk. So breast milk that has been gone through, goes through as rigorous of a process as when someone donates blood, and that's being given to someone else. So it's a very rigorous process that they go through. So if these babies are getting donor milk, it's going to really decrease or not affect them as far as necrotizing enterocolitis. So it's basically sepsis of the bowel. It is very severe, and it can be life-threatening. So you want to really make sure that your assessment is spot on, and you're catching this early. So it occurs basically at the initiation or the beginning of these enteral feedings. So what you're going to see is these babies are going to have problems. You're going to see that whole triad I talked about before. They're going to have respiratory issues. They're going to have unstable body temperature, low body temperature, very lethargic. When these babies get septic, again, they're actually going to have hypothermia, when we as adults or older, or your pediatric population gets septic, they may have hyperthermia. These babies will have low body temperature. But the biggest thing you're going to really, that's going to be really standing out is these babies. You'll see this visible bowel loop. So they're going to get very distended. Their abdomen is going to be huge. It's going to be really distended. When you may see bloody stools versus, the green or the yellow stools. You're going to see a bloody stool, very tender abdomen. They may have vomiting, or they're going to be, on NG. You may have increased gastric residuals. Remember, when you're doing tube feedings, you're checking for residuals. So you're going to be seeing this increase in these residuals. Babies are going to be really lethargic, very, just not well. When you're studying this, if it's been a long time since you went over tube feedings and enteral feedings, please revisit that, because we're going to be doing the same things with babies who have enteral feedings, whether they're babies or they're adults. We're going to, be checking for placement. You're going to be, measuring the same way. So just kind of revisit that. Here's a picture. If you look, I'll move my cursor over there so you can see in this baby. Can you see those visible bowel loops there? That's what we're talking about when we talk about these visible bowel loops, and it's very distended. This baby's very small, so that's, believe it or not, that's very distended. It's hard to see that this distension, but if you look here in the base, you can see that the abdomen is very distended as compared to the rest of the body. So it needs to be treated with antibiotics. They're going to do an send the baby down for an, if the nurse or the physician suspects it, it's immediately, they need to treat this immediately before this baby gets septic. They may actually have, if they don't treat it immediately, they may have to remove a lot of the bowel, and some babies will have a permanent colostomy. We want to, they may have temporary colostomies due to it, but we want to make sure that we're not having, causing a permanent colostomy. Blood cultures, they're going to be, they want to see what antibiotic is working, and we'll work on this. So blood cultures, and remember, when you're doing blood cultures, when do you start the antibiotic?
After
you draw the cultures.
Correct. So you can draw the cultures. Now, do you have to wait for the results to start the antibiotics?
No.
Correct. So grab the blood cultures, send them down, and then you can start the antibiotics. Other labs are going to be looking at CBC stool cultures. They're going to be doing stool cultures, electrolyte panel. That's supposed to be ABGs, not ABSs. So if you want to fix that in your notes, it should say ABGs, coagulation studies, and then medications is antibiotics. And this is really big and key. I kind of put it in red for you. Medications is antibiotics. And also you need to stop the feedings. You need to discontinue these feedings immediately. So if you're seeing these bowel loops and you're seeing all these other symptoms, stop the feedings. Call the physician, get this baby down for an x-ray, get, blood cultures drawn. This baby's going to be NPO until they get the results, because they're going to pretty much, one of the treatments is bowel rest, get those antibiotics on board. Analgesics, obviously, if there's blood pressure problems, antihypertensives, get fluids in. They also might do what's called gastric decompression as well. And then, if needed, this baby's going to surgery. At this point, the bowel may be very necrotic, so they may need to remove a portion of that bowel that's necrotic and then resect that. The babies may come back temporarily with a colostomy, and then they will then, for later down the road, reverse that, as long as that's caught early on. Any questions about necrotizing enterocolitis? There's many questions about that, so I want to make sure you guys understand that. So again, just some key things with that is it's sepsis of the bowel. These babies, when they're septic, they're actually going to get hypothermic, not hyperthermic. So they're going to have low body temperature. It's with your enteral feedings. You're going to see these visible bowel loops. You'll see signs of sepsis. You'll see respiratory failure, hypoxemia. That's what a bowel loop will look like. And then medical management is you need to, to diagnose it is an abdominal x-ray, get some blood cultures and labs, and then treat it. You're discontinuing the feeding. The baby's going to be NPO until they kind of figure out what's going on, or if they're going to be sending the baby for surgery, and then IV antibiotics. All right, the next one we talked about from respiratory distress, one of the issues that we were concerned about is retinopathy of the prematurity. And that occurs with prolonged exposure to high levels of oxygen. So it's very common in preemies because they have a lot of medical issues, and one of them is respiratory issues because their lungs aren't formed. So they're getting a lot of high dose oxygen. So the retina is not completely vascularized and it's very susceptible to stress and injury. They may not notice this initially because they're not doing the eye exam until until a couple weeks after birth. So they may not notice it right away. And the big key is to identify it as early on as possible, prevent it. Trying to lower that oxygen levels and prevent that because complications to retinopathy of prematurity is blindness. And we want to prevent the baby from being blind, obviously. And different things they can do with treat it as, lasers, cryotherapy. So there's a lot of different surgeries that they can do to treat the baby. But the big takeaway I want you guys to know is it's complications is blindness, and risk factors is due to those high levels of oxygen. So we want to really be careful with these babies with RDS, with respiratory distress syndrome, that we're really trying to get them off or keep the oxygen at the lowest point that we can still have good outcomes, if that makes sense. Post-mature means that baby has been cooking just a little too long. So these are these babies that are born after 42 weeks gestation. And a lot of times people will say to me, well, why aren't they, inducing labor? They're looking, they're going to do ultrasounds or checking the size of the baby. A lot of times they may think that maybe there's a miscalculation in the due date. So just different reasons why. And I think every OBGYN may have a different theory on when they're going to induce. But basically what happens is the baby, after your 40 weeks, the placenta starts to decrease in its functioning. So you're going to, it's kind of worn out. It's designed to be there for that, for the up until the 40 weeks. And then the baby is to be born. So you're going to see this baby's going to have one of the big things you're going to see with these post-term babies is really dry, cracking skin, because they're going to be losing a lot of the mom's going to have a decrease in her meconium. You're going to see low blood sugars with these babies, these larger babies. A lot of times they're larger. You're going to see cold stress. You may see birth trauma because, again, they're larger than your term babies. So a lot of different issues. You actually see an increase in mortality in these post-term babies versus your term babies as well. So again, assessment findings, you're going to see these dry, crack skin, because they're not going to have that vernix and that lanugo. So remember, in your preterm, you're going to see these preterm are going to have a lot of lanugo and a lot of vernix on their skin versus these post-term. So that's a good differentiation for you. Their body's going to appear long and thin, and you may see meconium in the fingernails, on their umbilical cord, on their skin. So they may have this meconium staining. So we want to treat these babies if they need oxygen. Remember, be really careful. Again, oxygen therapy causes what? What did we say before? You got it. Retinopathy of, yeah, of the premature infant, right? And even though these guys are post-term, you're like, okay, so it's they still call it retinopathy. Also, you want to watch for hypoglycemia, and you want to monitor their their blood levels and check to see if they have polycythemia. And I think I was talking about that back in here. They may have this polycythemia, which is a response to the increase in the production of red blood cells, which respond to their having hypoxemia from the delivery and from being post term. All right, so signs of hypoglycemia. Think about the same things that you see in your adult population or when we talked about gestational diabetes. So jitteriness, irritability, poor feeding, apnea. They're going to have that grunting breathing. Remember, we've seen that grunting breathing when we were looking at respiratory distress, and very lethargic. So basically, what is the low point for hypoglycemia in these newborns that I want you to know?
40.
40, very good. So what do you think? What do you think we would do initially? What would you do initially if your adult patient had a low blood sugar? If they're alert and oriented and they had a low blood sugar, what would you do?
Give them a snack.
What's that?
Give them something to eat or drink that has
Correct.
sugar in it.
Correct. So the same thing. Get these babies to feed. You're going to see this a lot of times in your breastfed babies, more so than in your bottle fed babies, but get these babies to feed. That's the first thing that you want to do. They used to years ago treat them with sugar water, but now they don't. They want to get these babies to feed. They don't want to confuse them, and they don't want to get in the sugar water initially. Monitoring their INO. So there's going to be frequently checking these babies and encouraging mom to nurse or bottle feed the babies. Next one is meconium aspiration. We talked about that during labor and delivery. So when the woman is in labor and her membranes rupture, if she has any amniotic fluid in the membranes, then that is going to, the baby can aspirate that during the birthing process, and that can cause not only respiratory distress, but it can also cause bacterial pneumonia, and the natural surfactant, and this is where you have your post-term or your term baby that has sufficient surfactant, but then has aspirated this aspirated this meconium, and it inactivates the surfactant. So these babies, you'll see these babies having respiratory distress, and these are those babies that would be getting surfactant, even though they were term. Clinical manifestations, you're going to see, again, that triad. You're going to see these babies having difficulty breathing. You're going to see low blood sugar, low body temperature. If they, if you're listening, you're going to see, you're listening to the lungs, you're going to hear like some bronchi. You may see that staining. Remember, we talked about that post-term. You're going to see the staining of the meconium on their nail beds and their cord and on their skin. These babies may have really low ABGARs when at first, decreased fetal activity, slowing of the heart rate, and you may see presence, again, signs of distress. So treatment is basically just, you're treating it symptomatically. So if you just need to suction and kind of stimulate that baby to to get everything out, that's best case scenario. You're suctioning and you're stimulating, you're drying the baby and cleaning up the baby, and nothing is working. Then we're going back to what we saw in the beginning of our lecture, where we talked about how you're going to be treating the baby with respiratory distress that's going over to the NICU. So then we're going to be starting our resuscitative efforts again. This baby's going to be transferred to NICU. We're going to be maintaining body temperature. They may get an umbilical arterial line. Did you guys see the umbilical arterial line access in that first video where they actually were putting all the medications through the umbilical cord?
Yeah, that was pretty cool.
Yeah, so they'll be accessing that. Again, they may be getting high oxygen concentrations, but again, we're watching that that oxygen. Obviously, we're not going to withhold oxygen, but we also know the consequences of using the oxygen. And then these babies will be getting surfactant replacement. All right, and why is this video not working? Let's see. Hold on a second. Okay. All right. This is a baby with meconium aspiration syndrome. If you go to watch this later when you're studying, sometimes they're coming up that they're inappropriate. I guess because they're doing invasive treatments with the baby. So anyway, you're going to see this baby that was born with meconium aspiration. It's pretty rough how they're suctioning this baby. They're going to go through it first, and they're going to see the video. I'm gonna pause there. They go over all the information first, and then they go into this really rough video of where they're suctioning this baby.
Tá ligado aqui na luz, né? Totalmente desocupado. Vamos estimular a maneira aqui. Obrigada. 45 segundos. Me dá um amor. Dá um amor. Vem pra cá, Roberto. Aperta, solta, solta. Pega o aspirador, vai aspirar a boca dele. Prepara o oxímetro aí de pulso. Bota o estetoscópio aqui para escutar ele. A frequência cardíaca tá boa. Bora.
Okay. So if you want to go back and watch that, just remember you have to click on to here because they I guess it's age restricted or whatever. All right, the next thing I'm going to talk about is intrauterine growth restriction, or IUGR. You're going to see a lot of this of the complications and the signs and symptoms and some of the factors for IUGR as you do for small for gestational age as well. One of the biggies here is that lack of prenatal care, because they're not following up your age extremes, very, very young and older than 40. You'll see this in your low socioeconomic status, poor living conditions, poor nutrition. You'll see this intrauterine growth restriction. Also big on women who have substance abuse issues. So these babies are going to be smaller than gestational age, and they're going to have restricted growth. Also, some other complications: maternal heart disease, sickle cell with the mom, PKU, lupus, and asymptomatic pyelonephritis. Some fetal issues with these babies that have IUGR is a lot of different types of infections. So you'll hear this term torch infections, which is your toxoplasmosis we talked about. These things we talked about back in the beginning. We talked about prenatal, when we're looking at prenatal care and are testing them for all kinds of stuff. Syphilis, congenital malformations. You'll see this with your trisomy 21. You'll see these IUGR. So even though they're term, they may be very small for term versus a infant that does not have any chromosomal disorders. And then small for gestational age. I link this highly with women who are smoking during pregnancy. And as much as it sounds kind of hard to say, but these women who are smoking, it's kind of like these babies are, of newborns that have moms who are abusing substances. They don't want to have them go cold turkey, because we can't tell how the baby is doing if mom goes cold turkey. So we want to have them lower their intake of smoking versus going cold turkey with smoking, because we're again not able to monitor the baby. But you are going to see these babies are going to be smaller due to that. And then these are just a bunch of different complications from these babies that are small. So a lot of the stuff we've already talked about already. We've talked about respiratory distress. We talked about aspiration, hypothermia, hypoglycemia, polycythemia, and then fetal hypoxia. So these are just different terms. You'll hear these terms used as well when we talk, about the small for gestational, and you'll hear those with your preterms, and you'll hear those with your postterms and your aspiration syndrome. So just kind of be familiar with that terminology. Any questions as I'm going through? I'll pause if anybody has any questions for me. Everybody good? All right. Some nursing actions: assess for respiratory distress. Any gross anomalies, you're gonna be doing your full assessment, checking for any meconium staining, making sure that they're maintaining that normal temperature, because we talked about that triad. Making sure that we're decreasing and monitoring their blood glucose levels. Just kind of talking about some nursing care plan for a small for gestational age. So I kind of put some nursing diagnoses: impaired gas exchange, risk for infective thermoregulation, risk for injury related to those low blood sugars. And again, I want you to go with that 40. This one here has 45. So just keep with that 40. Signs and symptoms. We talked about signs and symptoms of low blood sugar. Altered nutrition would be another one, because remember they're going to be poor feeders. And risk for impaired parenting, especially if these babies are whisked off to the NICU. Mom and maybe mom they're working with mom or managing mom. And so the baby's in the NICU and they're working with the baby. So impaired parenting. Large for gestational age, the most common cause is maternal diabetes and uncontrolled hyperglycemia in the mom. Male infants tend to be larger than female infants at at gestation. And then another um, group of infants that are at risk for being large for gestational age is these babies that have this transposition of the great vessels. I'm not going to go into a whole lot of detail with that. This is one of those things. This is one of those congenital abnormalities when basically the whole right side of the heart is on the left side and the left side of the heart is on the right side. So it's a complete opposite of their cardiac anatomy. And these babies need to go in for surgery pretty much immediately after birth. But these babies tend to be larger than babies that do not have transposition of the great arteries. You'll hear the term macrosomic. It's another term for large for gestational, more than 8 pounds, 13 ounces. These babies a lot of times have poor motor skills. They'll have difficulty regulating their behavioral states, maintaining quiet status. They'll have feeding difficulties. You'll see these are the babies that are going to have these birth injuries because they're so large coming through the birth canal, or they're going to be at a higher risk for having mom having a C-section. We talked about why their blood sugars are low, about the blood glucose from mom is basically discontinued after that baby's born, and they're still producing insulin in effect to that. These babies, you'll see they'll have tremors, they'll have hypocalcemia from these diabetic moms due to the low magnesium secondary to the urinary calcium excretion. So these babies may have hypocalcemia, so they're watching their calcium levels, they're watching their blood glucose. They're also at a higher risk for having polycythemia as a compensatory mechanism. So a lot of different issues with these large babies. And again, I told you these babies have a higher mortality rate versus your normal birth weight babies. Frequent heel sticks. They're doing frequent heel sticks because that's how they're getting their blood work done. They want to get these babies eating early to help offset that low blood sugar. And if there's any injuries, they're treating them and identifying and treating any birth injuries related to that large for gestational baby. Again, common complications, even though they're large, they still have some of the very similar complications as the premature. So again, I told you the low blood sugar, low calcium, birth trauma, which you wouldn't see in the small, respiratory distress, even though they're mature, their lungs may not be, they may be less mature, and they may have decreased surfactant, or if they aspirated meconium as well. And you may, again, see that congenital malformation. So you want to monitor and treat for those low blood sugars. If the babies aren't maintaining any oral feedings, whether they're breastfed or bottle fed, if they're poor feeders, IV glucose. The next issue, I talked about this, about group B streptococcus. So group B streptococcus is, they're getting this because it's not identified in mom. And so when mom delivers, remember if she's GBS positive, she's going to be getting what? When she comes into labor and we identify her as GBS positive, what are we doing?
Having antibiotics.
Right. So she's getting what antibiotic is the antibiotic of choice if she has no allergies?
Penicillin.
Right. So she's going to get at least two, it's basically every 4 hours, at least 2 doses they want to get into her before delivery. Because and their moms are screened around 35 to 37 weeks. If they didn't screen, if mom's preterm, they will prophylactically administer the antibiotic. But if she has a precipitous labor, or if she comes into the emergency room and she delivered at home or on the way in, we can't, account for that. So these babies are at high risk of getting septic because of developing the group B streptococcus when they're going through the birth canal. So again, you want to watch for signs and symptoms of sepsis, low body temperature, hypoglycemia, respiratory distress. Make sure you're maintaining standard precautions for yourself, administering the antibiotics and monitoring these babies. These babies will go over into the NICU for higher level of care. For congenital anomalies, stick to my PowerPoint slide here. There's a lot of information you can get into, into these different congenital anomalies. This is, I want to just keep this kind of simple, kind of like that medication slide, keeping it kind of simple. So what you need to know is right here. You don't need to go into your textbook and read into more detail. So the different things I want you to know is right here. So cleft lip, cleft palate. It's an opening in the lip or palate. What do you think the issue would be? What would be like a nursing diagnosis for a newborn with cleft lip or cleft palate?
Ineffective
or-
eating.
Yeah.
Correct. So ineffective eating, aspiration, also ineffective bonding. Maybe the parents are did not know and are really having a hard time with a child with disabilities. So infant wise, feeding, aspiration, infection also. All right. Tracheoesophageal atresia. And a lot of times these babies don't catch this in the hospital when these babies are born. And then mom's coming back for follow-up appointments and the baby's losing weight. So it's very common. It's a failure of the esophagus to connect to the stomach. And I want to say it's common. It's kind of a simple fix. I've seen several babies with this. And so they're having a lot of reflux and spitting up and kind of failure to thrive. They are getting some nutrition so that they follow up on that week appointment or a 2-week appointment, and they're dropping weight. And then when they look into it further, mom's telling them different things that are going on, and they bring them in and do surgery. Another one is PKU. It's the inability to metabolize the amino acid phenol. It's tough to pronounce. Phenylalanine. Next one is galactosemia, and that is the inability to metabolize galactose into glucose. Spinal bifida, you're going to see a protrusion of meninges and or the spinal cord, and it can be very minimal or it can be very severe depending on the severity, is whether they're going to need surgery immediately or in the near future. Down syndrome is a chromosomal disorder with the chromosome 21, and you'll see with these babies, they can be, again, it can be across the spectrum. Some can have absolutely no problems, and other ones are going to have problems cardiac wise, nutritional wise. But your features are, you'll see a flat facial feature with small nose. They may have a protruding tongue and a simian crease. You'll see that in their hands, and they may have hypotonic muscles. So it may lead to like tracheomalacia, where they have kind of like a floppy airway. So here are some of the pictures of some of the ones that we talked about, and I have in there just to kind of give you, what they look like on the other end. So you see, whoops. Oh, I didn't talk about the hip dysplasia. Over here's another one is a hip dysplasia, spinal bifida. So this one here is going to need to be treated. Where you see the spinal bifida oculata, you may just see a little bit of a tuft of hair down along their spinal column. So some more information I want you to know about cleft lip. We talked about how it affects the nutrition status of the baby. So you want to monitor for signs of dehydration and nutritional deficits. educating the parents on feeding. These babies can be breastfed. They just, you want to work with a lactation consultant. They have different devices and stuff that they can help. Make sure you're positioning the infant to make sure that you're facilitating drainage so these secretions aren't going into there, causing infection or aspirating, suctioning as needed. And I have a little video here. How are we doing on time? We're doing pretty good on time. Let me put this. This goes over some feeding with the babies with cleft lip.
When a baby has a cleft lip and no cleft palate, there are not usually any special considerations needed for feeding. When a baby has a cleft of their palate, a thorough feeding assessment by a cleft specialist nurse is needed. She will help parents develop a feeding plan and will give guidance and support as parents learn the techniques for feeding their baby. Feeding can be a great source of worry to parents, and it's important that the advice they get is prompt, accurate, and individual to meet their baby's needs. In this film clip, the cleft specialist nurse has come to the maternity unit just 2 hours after baby Jasmine is being born by caesarean section. The cleft specialist nurse assesses Jasmine's oral reflexes in readiness for Jasmine's first feed. Jasmine is very sleepy but manages to take some formula milk. The initial feed may be given using a glass bottle and an orthodontic teat. Over time, the milk will be given in a bottle developed specifically for babies with cleft palates. This bottle enables a person feeding the baby to gently squeeze the bottle to push the milk out. This is needed because babies with a cleft palate are unable to form a vacuum in their mouths to make an effective suck. As breastfeeding also requires babies to form a vacuum, breastfeeding is usually not possible. When expectant mothers know antenatally that their baby has a cleft and that there is a chance that the baby also has a cleft palate, provisional plans can be made for feeding before birth. The cleft specialist nurse may recommend expression of colostrum, which is the first milk the breast produces. This production begins before the baby's birth. Although breast milk can be expressed using a breast pump, many mothers who had planned to breastfeed feel very disappointed when they're unable to do so in the conventional way. For some mothers, the feeling of loss about this are very strong. Parents quickly become experts in assisted feeding techniques. When it's time for weaning, the cleft specialist nurse will be available to give advice and support once again. Although parents tend to worry a lot about whether weaning a baby with a cleft palate will be more difficult than an average baby, this is not usually the case. Until the palate is surgically repaired, often small amounts of milk or semi-solid foods come down the baby's nostril. This is because the tissues that normally separate the nasal cavities from the mouth are not in the right place.
All right. Galactosemia is you're going to be giving this baby a soy-based formula because of the galactose present. And if you want to highlight this, this is one of those contraindications to breastfeeding because the baby cannot metabolize or eliminate the lactose and the galactose in the milk. So this baby needs to be given a special soy-based formula. Spinal bifida, you want to protect that membrane. Remember I showed you that one where you can actively see not the little hair top, but we can actually see the meninges on the outside. So the baby's going to need to have surgery. So in the meantime, you want to protect that membrane with a sterile covering because we don't, the highest risk is getting is infection, and you want to prevent that from drying. Observe for any CSF leakage. Handle the baby very gently. And these babies are going to be positioned prone. Remember, supine, you can't position these babies supine because that's where the meninges are on the outside. So these babies are going to be positioned prone. So these babies are, it's not, you think of, back to sleep. The babies are on their back, but these babies are going to be on their belly. These babies are going to be carefully monitored. Again, prevent infection is big key. So really making sure that you're teaching the parents to be cleaning these babies if they're going home and then they're going to be coming back for surgery. Depends on what they're doing. If they're going to be staying in the NICU, if they're going to be going home. But if they're going to be going home, you want to really teach them to keep that area especially clean, and of urine and feces, and assess the baby for any signs of increased intracranial pressure. So again, it really depends if they're going home or not. And then I just put here for Down syndrome, I told you that it's a chromosomal disorder of the chromosome 21. And I just want to share my grandson. He's going to be 5 in July. And so I told you some of the babies, you have all kinds of issues, feeding issues, and they need to go for heart surgeries and different things like that. Basically, the only issue that my grandson had is my daughter did not know that he had Down syndrome. She declined the testing for that because she did not want to, she wasn't going to change what she would do if she knew. So she declined it. Now she did have the testing for the other 2 children because they wanted to be prepared. Not that it was going to change her pregnancy pathway, but just to be prepared. So he actually was born and we did not even know. He looked great. And about 6 hours after he was born, my daughter was working with the lactation consultant. Myself, her husband was deployed, and he went cyanotic and never could figure out. The only issue he had was they basically attributed to he had a floppy airway due to the Down syndrome, with low tone, but he actually had pretty decent tone everywhere else. So he was taken to the NICU, and they kept saying he's not going home until they could wean him off of oxygen. Well, they could not wean him off oxygen. Everything else was absolutely fine. My daughter breastfed him for over a year. He followed up with all the therapies, physical therapy, occupational therapy. She did everything with him, and so he went home on oxygen. He was on oxygen for a year, and the only concern is if he gets any type of any type of respiratory infection. The one picture there, he has he got RSV, and they live now they live in North Carolina, and he was in Duke University. So I went down with him when he was in the pediatric intensive care unit, because as soon as he got the RSV, his O2 sats would drop. So anytime he has any kind of respiratory infections, his sats drop. But other than that, he's doing great. And that is it. I have chapter 17. I'm not sure if I have it recorded. I'm going to record it. I will double check for you, but chapter 17 will be on stillbirth, intrauterine fetal demise, which will also be on exam 3. And that will be a recorded lecture. So I will have posted for you. I'm going to stop sharing. And I'm going to